Okay, like I was saying, I say good afternoon, or we're still in the morning. Okay, almost afternoon. Good afternoon, ladies and gentlemen, and please let's listen to this lecture. Don't unmute your mic. Despite that, people still muted their mic. See how difficult it can be to control. Yes, occlusion and dysfunction is the topic before us that I'm going to be treating today, and I expect everybody to pay attention. Don't come online and waste your time. If you are making noise, you are wasting your time. Please pay attention. This lecture, I've taken your attendance already, but if you have not written your name, please do so in the chat box so that you can listen and we can get your attendance. If this is your first time of joining an online video lecture, I know you'll be playing with a lot of things, but can't you spare us a while now so that we can really concentrate and you gain something for 1 hour or less that we're going to be together? Very important, very, very important. Please don't unmute your mic for the time I'm speaking. Now, the occlusion and dysfunction. And when we're talking of occlusion is not only in dentistry, but this is occlusion in dentistry. Occlusion means coming together, like I said, and dysfunctions are the problems that are associated with occlusion. Now, I said in the learning objective, by the end of this lecture, you should be able to define and understand occlusion as it applies to artificial and natural dentition. Then you should be able to identify different dysfunctions associated with occlusion. You'll be able to identify angles that Edward Angles classification of occlusion. Edward Angles is regarded as the father of modern orthodontics. You will know what his classification of occlusion is. Identify components of occlusion, objectives of occlusion, and there are some terms I put together that you'll be able to see. What occlusion is and what it is not. Occlusion is about relationship between upper and lower jaws, involving the teeth and all associated members of the oral cavity. I take that again. Occlusion is about relationship between upper and lower jaws, when the teeth and associated members of the oral cavity is involved. Okay, so and the oral cavity, the associated members of the oral cavity that are involved include the mucosa, the alveolar ridge, the temporal mandibular joint, short form TMJ, the muscles of mastication, the bones, and cartilage. Malocclusion is incorrect. That is the opposite of occlusion. That is what occlusion is not. It's incorrect and misalignment relation between the arches when they are approaching occlusion, when they are trying to come together. That's malocclusion. Incorrect or misalignment relation between the arches when they are approaching each other, when they are about closing. That is malocclusion. So let's begin like this. Occlusion can be considered as natural. We are talking of occlusion, that natural occlusion evolves when a patient has all his teeth in place, no extraction. That is natural occlusion. Artificial occlusion is involved when a patient wears denture, full, upper and lower denture. They will call it artificial occlusion. And what are the objectives of occlusion? The objective of occlusion is to replace teeth and to preserve the residual ridge. These are the two main ones. There are more. Okay. What are the components of occlusion? I told you the tooth, the whole groups of teeth in dental arches. That is, when you consider the teeth in the lower arch and the upper arch as a group, that is one component of occlusion. Then the relationship between the arches when they're in centric or eccentric positions. Then you look at the temporal mandibular joint. The temporal mandibular joint, we get to know, is that joint that connected the lower jaw to the skull. Definition of types of occlusion. Definitions of types of occlusion. Occlusion is about contact between maxillary and mandibular teeth. I told you earlier it's about the arches coming together involving the teeth. And this happens when a patient is chewing and when the jaws are in rest position. So we can recognize centric occlusion, which means a static relationship. The eccentric relationship is, eccentric occlusion is a dynamic relationship between the upper and lower jaw. So when you are chewing, for example, there's mobility in the jaws. That is eccentric relationship. But when the jaws are in rest position, that is, they came together, that is centric occlusion. Then centric relation. Scientists are in doubt about what should be the stable meaning of centric relation. But I put this together for you so that you can understand. Because even the subject of occlusion is a controversial subject. So people, dentists, professionals have different concepts of occlusion. So what is centric relation? Centric relation is defined as jaw-to-jaw contact. When the upper and lower jaws are in contact, that is centric relationship. And this usually happens when teeth are not involved, when it is an edentulous case. Centric occlusion is tooth-to-tooth relationship. That is when the teeth are in contact. That is centric occlusion. Centric occlusion and centric relationship is when we are considering the relationship between an upper and lower teeth when they are fully dented. So when centric occlusion and centric relation can only happen when the teeth of upper and lower are in occlusion. They are acting together. That is when we have centric occlusion and centric relation. Then what is balanced occlusion? It's also a static relationship that exists between the incising and occlusal surfaces of maxillary and mandibular teeth. Balanced occlusion, I take that again, is a static relationship when the maxillary surfaces and the incising edges of maxillary and mandibular teeth are in contact. That is balanced occlusion. Balanced occlusion, articulation is different. It's a bilateral simultaneous occlusal contact of the anterior and posterior teeth when they are in excursive movement. Lateral excursion, where they are, when for example, you are chewing, you are biting, and the teeth are, the jaws are moved against themselves. That is balanced articulation. Okay, we move forward now. I try to show you here bilateral balanced denture occlusion with anatomic position denture teeth. You will see in the image, you see the relationship between the upper and lower teeth. This is protrusive. This is a protrusive relationship. And you see the balancing relationship there. You can see that, you can see gap between the incisor edges of the teeth. You can see they are not making contact. And the working relationship is when they are in full contact. It's similar to centric relationship, though not exactly, because centric is not dynamic, but working relationship is dynamic. I just try to show you so that you can see the difference pictorially. You are familiar with this, and this will be of serious help to you. This is overjet and overbite. Because when you are talking of relationship, which is all about occlusion, you should understand the relationship between the upper and lower anterior, relationship between the lower and upper posterior. And in defining the relationship between upper anterior and lower anterior, you talk of overjet and you talk of overbite. Some of you are very familiar with this. So the overbite and overjet relationship are very important when you are considering occlusion. So you can see how it is measured there. Overbite is vertical overlap, while overjet is horizontal overlap. You see how they are measured there. So very important that you take note of this. Again, there's a very relevant definition here that will help you to understand occlusion. This is incisor guidance. Incisor guidance is an angle formed by the horizontal and vertical overlap of anterior teeth in relation to a horizontal plane. Let's say we draw a horizontal plane, a line that is crossing the incisor edges of the upper anterior. And we'll take another line too that bisected it, that is taking the angulation of the anterior upper. When we look at it, the angle that is formed by these two lines is called incisor guidance angle. So when it is so wide, when it is so low, so close, there are different occlusions that are guided by that. Now let us look at the third image. That is image C. In image C is showing us zero incisor guidance. In this case, there is no incisor guidance at all. In A, there is steep incisor guidance. In B, there's medium incisor guidance. Why is this knowledge important to you? They're important in that it is only when you have the understanding of the relationship of upper and lower anterior teeth that you'll be able to understand what occlusion is. Because occlusion is about contact between the upper teeth and lower teeth, regardless of whether they are posterior or anterior teeth. So that is incisor guidance angle for you. It is formed by horizontal and vertical overlap of the anterior teeth in relation to a horizontal plane. We move. Now, this will help you to understand also the different curves of a typical posterior teeth. A curve is an eminence on a tooth. It's an eminence on a tooth. Curves can be posterior, it can be anterior. These are, let me say, projection, elevation on a tooth. And this image shows you a lot about how to understand different sides of all these curves. So until you understand them, it will be difficult for you to be able to define occlusion and understand it. Of course, you know that we have to a tooth, we have a buccal surface, we have a lingual surface, we have a distal surface, then we have a mesial surface. So the mesial pit, the mesiolingual cups, the lingual groove, the distolingual groups, everywhere, every side or every surface of a tooth is defined by the name of that surface. If it is lingual, you are going to define it according to that side of the tooth. That is where you have distolingual cups, distolingual groove. If it is buccal, you are going to be talking about buccal groove, distal buccal cups, mesiobuccal cups. If it is distal, so and so on, distal cups, distal buccal cups. Now area nearest to the buccal area, but it's also close also to the distal end. And you know the distal end is any area away from the midline. So the understanding of these different corpses and the fact that a tooth typically has 4 sides. The additional one will be the occlusal surface. Show to you a clear understanding of how you can understand occlusion. So you know that I told you earlier, curbs are eminences on a tooth. Canine has its own, just 1. Premolar have 2, and molars have 4 or 5. Depends on the tooth you are dealing with. So every tooth has its own eminence, and they are so defined. Now we talk of Edward Angle's classification of malocclusion. Edward Angle is reputed to be the father of modern orthodontics, and he has so designed classification of malocclusion, and he defines it as the relative position of permanent maxillary first molar. So the reference point that Edward Angle used in defining class of malocclusion is the first permanent maxillary molar. That is the reference point. You get to know in the course of this lecture what that means. The canine can also be used to define malocclusion, where the first permanent maxillary teeth are missing, tooth is missing. So, and he defined this, that the class 1 of malocclusion as when in relation to the incisor now, as mandibular incisor when it makes contact with the maxillary incisor in the middle third or on the cingulum of the palatal surface. So when there's a surface, when the incisor of lower is making contact with the third of the palatal surface of upper anterior, is class 1 relationship. You get it clearer as we move along. The class 2 is mandibular incisor contact the maxillary incisor on the palatal surface in the gingival third or posterior to the cingulum. This class may be further divided into 2. I think you need to understand and read this one often. Includes maxillary incisor which are proclined about 90%. You need just to know this because there's no way you measure 90%, but just to know how the different classification or subdivision rather of class 2 of Angle's classification of malocclusion. Then you take of division 2, which includes retroclined by 10% of the incisor. So, and that leads to decrease of the vertical overlap. It is rather termed as overbite. Okay, then the class 3 malocclusion is mandibular incisor occlude with the maxillary incisor on the palatal surface in the incisor third, specifically or anterior to the cingulum. These are very technical things that we need to understand and be able to learn them, sometimes offhand, so that if a question is asked, you'll be able to answer them very well. But this will become clearer to you as we go along. So this is Edward Angle's classification of malocclusion. You can see the picture there. You can see the picture there, the class 1, the class 2, the class 3. Class 1, class 2, class 3. Class 1, we previously have defined it, is the mandibular first molar when it occludes mesially to the maxillary first molar. You know, we talked about the anterior previously, but now we are talking of the relationship between the posterior. You know, I told you earlier that Edward Angle's classification of malocclusion takes the first maxillary molar as the reference point or the canine. So mandibular first molar when it occludes mesially to the maxillary first molar with the mesiobuccal curbs of maxillary first molar occluding in the buccal groove of the mandibular first. You can see what we're talking about now. The mandibular first molar occlude mesially to the maxillary first molar. You can see the relationship in the image here. I believe everybody can see the image. You can see the image that the mandibular first molar occlude mesially to the maxillary first molar. That is class 1. Class 2 is mesiobuccal corpus. The mesiobuccal corpus, you can see it here, of the maxillary first molar occludes anterior to the buccal groove or the mandibular first molar. You can see it here. The mesiobuccal corpus. You know, I told you earlier that you name a corpus as per the surface of the tooth. Mesiobuccal. That is nearest the middle line, nearest the buccal side. So the mesiobuccal corpus of the maxillary here, see where it is lying, that is of the first molar, where it's occluding anterior to the groove of the mandibular first molar. Now, you see that the mandibular first molar here is backward. Why? Let me use that language so I can understand me. Why the maxillary first molar is moving anterior. That is the description is trying to give you there. That is the mesiobuccal corpus of the maxillary first molar. Where is the maxillary first molar? You can see my pointer. That is it. Occludes anterior. You see now, the mesiobuccal corpus here is this. If you can see my pointer, is occluding anterior to the buccal groove of the mandibular first molar. The groove is the line that tends to divide the teeth or a tooth into two. So when this mesiobuccal corpus is occluding of the maxillary first molar, is occluding anterior to the buccal grooves of the mandibular first molar, then you define that as class 2 malocclusion according to Edwards-Angles classification of malocclusion. Then the third class of malocclusion is, you see that it's like completely the first maxillary molar is almost off the surface of the first mandibular molar. That is class 3. See the definition. If the mesiobuccal corpus, where is the mesiobuccal corpus? That is when the line is crossing in the third class. If the mesiobuccal corpus of the maxillary first molar occludes posterior to the groove of the first mandibular first molar, then you define that as class 3. You can see the distinction. The picture should be able to show you a clearer understanding of this relationship. You know, we consider that of upper anterior before. Now we are considering that of posterior. That will give you a picture of what it looks like. Let's go further to the next slide. Now you will get a clearer picture here too. Here you can see the relationship, class 1, class 2, class 3. You recall that the last one we just said, the class 3, that the maxillary first molar is almost not biting on the mandibular first molar. That is class 3. The class 2, the maxillary first molar is anterior to mandibular first molar. In other words, the groove of maxillary first molar is anterior to the groove. I mean the corpus, the mesiobuccal corpus of the maxillary first molar is anterior, it's biting anterior to the groove of the first mandibular first molar. So this picture shows it clearly to you While the class 1, which is a normal relationship, is when the mesiobuccal corpse is biting on the groove of, that is of the upper, on the groove of the lower, the first molar of the lower. This gives you a clearer picture. You can see the relationship there. That is Edward Angle's classification of malocclusion. Let's look further. This is a dynamic relationship. You see how the animation is changing. Can you see? That is class 3. Where it is now is class 3. This is class 3. Then this is class 1. This is class 2. You can see that relationship. And you know the reference point in all these cases is always the first maxillary permanent molar. This animation shows you the relationship. And if you observe very well, in the class 3, you see how the lower anterior is overlapping the upper. And here, the overlapping of class 2 is so pronounced. So the overbite and overjet will continue to change each time that you are considering the Edwards classification of malocclusion. I believe that should be clear to many of us. Okay. Another important concept about malocclusion that you need to understand, about occlusion rather, not malocclusion, is cough of speed. Many times people don't understand what cough of speed is. Cough of speed is when you are describing this cough in relation to natural dentition. But when it is artificial dentition, that is prosthetic occlusion, we are talking of compensating cough. People used to mix them together. Cough of speed, compensating cough are same, virtually the same. The difference is that cough of speed applies to natural dentition. When you are describing this cough in relation to natural dentition, you call it cough of speed. But when it is involving prosthetic occlusion, that is where the patient is wearing denture, then it is called compensating cough. Please, let's take note of this important concept. They are all very important in our understanding of the concept of occlusion. There we are here, plane of occlusion. Plane of occlusion is also a line that is connecting the tips of your incisor to distobuccal cups of the most posterior tip on either side of the arch. You can see it. That is a line from the anterior. It's making like a triangular shape, connecting the first, the distobuccal cups of the posterior, the last posterior, that's second molar on one side to second molar on the other side. That is plane of occlusion. Cough of wheezing. Cough of wheezing is the buccal cups of mandibular posterior teeth when they are generally slightly higher. The buccal cups of mandibular posterior teeth, they are usually higher than the lingual cups. So if you take a line from the buccal cups of any posterior, and you try to draw it, if it connects with the lingual cups, the buccal cups, you are taking the line from the buccal cups now, it's connecting with the line, with the cups of the buccal cup, the lingual cups rather. It is going to descend down, that line will descend down to touch it. And if we continue this line to join, that is on one side of the arch, to join the lingual cups on the opposite side of the arch, that line goes up And to further touch the buccal cups of the posterior teeth on the other side of the arch, it goes up. So if you look at the line is, when it's touching the buccal cups of both sides and the lingual cups, the line is going to form a kind of a shape. It's going to coin a saucer kind of shape. And that shape, that curve is called curve of wisdom. Let me read this. Therefore, a line drawn touching the buccal cups, the lingual cups of same tooth on one side of the arch, if extended to touch the lingual and buccal cups of the tooth of opposing side of the same arch, is called curve of wisdom. Now you can know the distinction between the two now, the curve of speed, the curve of wisdom. Let me go back to curve of speed. All posterior curves do not touch the occlusal plane, but conform to a gentle anterior posterior curve known as curve of speed. So the curve of speed is a line. It draws usually an imaginary line drawn from the anterior. It touches the buccal cups of the mandibular posterior, and it goes up like that. That curve is called curve of speed. And these curves are very important to your understanding as a student of occlusion, and of they're also helpful when you are setting up, so that you know which tooth that is going to be, which cups is going to be raised up, and so on and so forth, and which one is going to go down. The different angulation and position of your setup is determined by all these curves. Now, curve of wisdom, we have defined it. Then this is further defining the curve of speed and of Monzon. Now, the B here, the lateral curve, this is showing you what I just described about curve of wisdom. You see, the line takes off from the buccal cups of this tooth. You can see my pointer, and it's touching the lingual cups. I told you the buccal cups should always be higher than the lingual cups. And it continues, that line continues, and it's touching the lingual cups on the opposite side of the arch, and it's touching the buccal cups. This curve is called curve of wisdom. Where this, the A, is the line that is the imaginary line, they're usually an imaginary line, that is taken off from the anterior, touching the buccal cups of all the posterior, and your setup should definitely reflect this. That is curve of speed. Your setup should reflect this. That is what will make your setup fine and good. So take note of that in all your setups. Now, the subject of occlusion, like I said, is very controversial. What is normal, what is abnormal is hard to define. So, but the clinician will always know what is suitable for a patient and be able to work hard to ensure that they implement the right occlusion for the patient. There's no one bad occlusion. It's difficult to say this is a bad occlusion. It is difficult to say this is good occlusion. The amount of the patient will define a lot and will determine a lot what occlusion will be. Now, that is occlusion and dysfunction for you. We'll be on for some minutes now, and I believe I am communicating with so many members of this class. Now, I will expect that you ladies and gentlemen, I will expect that you will be able to ask me questions before I ask you questions about today's lecture. It's a short one. We didn't spend much time. So please let me welcome your questions. You can unmute your mic, then speak to me. Let's share together on this subject of occlusion. Or if there's any part of the lecture that you don't understand, be free to let me know so that we can talk it together. And if okay, you want me to come back again, that is Abdul Talib. I don't know, you want me to go over everything again or specific slides? Please let me know what exactly you are saying. For anyone who could not speak, maybe your network or for whatever reason, you are free to type, just like Abdul Talib just did now. Type your question or your concern into the chat box. Then I will see it and be able to attend to your question. If you're not so free to make statement there, please do so that we can understand ourselves. Abdul Talib, I'm still waiting to hear from you whether you want me to go over all the slides again or you want specific slide you want me to explain to you, because I only see come back again, please, sir. Okay, I don't understand Edward Angle's, sir. Edward Angle's classification. Okay, do I see Baba today? Yes, we will take that. Can I get more questions too? Okay. Don't chat privately, chat direct, because I will still say it, and everybody will know that you asked that question. So, okay, okay, cough of monsoon. That is what. Okay, so I don't understand the occlusion. Okay, so how can class 2 malocclusion be corrected on a partial denture? Okay. Okay, let me do something now. Let me take it one after the other. Let me take that of Isaac Babatunde again. We will be able to understand. Let me share the screen so that we can understand, we can look at it together. I'm coming to share the screen with you again so that you can see it together. You want to know what Edwards Angle classification of occlusion is. But before I share that, let me start saying that to you, that Angle's divided malocclusion into 3. The class 1, the class 2, the class 3 malocclusion. I guess you mean that you don't understand any of them. But let me try to put them forward to you again, what Agui is saying. I say Edward Angle, I'm sorry to say that. Edward Angle is divided malocclusion into 3. And we define malocclusion by starting with the anterior and the mandibular relationship. Posterior relationship of the teeth. You know, when you're talking of occlusion, is involving, like I said earlier, the teeth, the anterior teeth, the posterior teeth of upper and lower arches. So it is not just about anterior teeth alone. It's not about posterior teeth alone. But let me take you to that. Let me take you to that. To that animation. Let me take you to the animation so that you can understand me. Now you can see now. I'll take you to an animation that explains the occlusion to you. This is the animation that explains the Edward occlusion, Edward classification of occlusion. Okay, sorry. Like I told you, this is class 2. Begin to understand it this way. Sorry for the break in transmission. You can see the Edward angles classifications of malocclusion. Like I said to the person who asked the question, it's divided into into 3. We have the class 3, class 2, class 1. Class 2, class 1, class 2, class 3. Okay, let's move now. I want the animation to show. Now, if you're looking at the relationship, this class 2, you will see the anterior is coming out more. Then look at the class 3. The anterior of lower is coming out far more than that of upper. It's not a normal jaw relationship. This is the class 2. The anterior of upper is projecting more. The class 3, the anterior of lower is projecting further. In normal relationship, you see that the overjet and overbite is okay. So that is how angles classify malocclusion. You'll notice that each time there's this animation shows, if you look at this side, beside the head of the man here, you will see the relationship of the anterior. The relationship of the anterior is trying to explain to you what class is. Now, but let me take it further and explain to you. This is the posterior. In class 1, this is a normal jaw relationship. In this case, the mesiobuccal corpus. Mesiobuccal corpus. If you can see my pointer, the mesiobuccal corpus is rest of the maxillary first molar. Sorry, when I say mesiobuccal corpus, I'm talking of lower and upper and lower, because Edwards takes first molar of the upper as a reference point, just as canine too. So the mesiobuccal corpus of the upper is engaging the groove of that of the lower. You can see the relationship, and it's engaging it posteriorly. Now, the distobuccal corpus is partially making contact with the distobuccal corpus of the lower. That is class 1, and it's a normal relationship. Class 2 is abnormal. In this case, the distobuccal corpus of the upper is anterior to that of lower. So you see that the mesiobuccal corpus is like completely off the surface of that of lower. If you look at it, class 3, it's like the corpus, the mesiobuccal corpus, is almost completely off the surface of that of lower. That is defining the Edward Angles classification from the perspective of the posterior. Now, if you look at this animation, if you look at the posterior, the anterior, you see that Each time it is class 3, the lower anterior is always forward, whereas the upper anterior in class 2 is usually forward, projecting forward. It's an unusual relationship. I think I've dealt with that. Then let us go to monsoon, which Abdul Muttalib asked about. This is curve of monsoon. The curve of monsoon, let me put it this way, it will be better understood here. This is curve of monsoon. I told you curve of monsoon, that line, the line that joins the buccal cups on one side of the arch to the lingual cups of the same tooth on one side of an arch, and it runs straight to join the lingual cups of the other side of the arch and join the buccal cups. That curve, if you draw that line is known as curve of monsoon. That is curve of monsoon. So it's different from curve of speed. Curve of speed is also an imaginary line that touches the canine, the anterior, and it touches the buccal cups and it goes to the last molar. They are usually like a trough. That is curve of speed. You try to know the decision now. Okay, let's go further to other questions that some people have asked. I'm trying to look at your question now. Somebody raised up his hand. You know how we're going to connect with that person now. So I'm trying to get your chat so that I can attend to. Somebody asked me, how do you correct in a partial denture? I think Shinoku also is trying to ask me, how do you correct malocclusion? Sorry, we are dealing with internet, and internet can be so erratic sometimes. I'm trying to see the chart so that I can deal with the question of everyone here. Sorry. Okay, please, you have to ask that question again, because I discovered that each time it goes off, the chart will be wiped off. So, but Ademola said, can we get the PDF of this presentation? Of course, even the video will be available for you to listen to me again. So you'll be able to get it. But you know you can't get PDF now. If you can get the video, I think it's better. The video will explain everything to you. Okay, so if I have dealt with your questions satisfactorily, if you can speak, speak. If not, just type there and say you are satisfied. So I will know you have dealt with it appropriately. Okay. Somebody said occlusion. That is Tijani Naimot. Occlusion is about relationship between upper and lower when they are in contact. And I told you we have centric occlusion, we have eccentric occlusion. Eccentric occlusion is when there's maximum intercuspation, when they are in firm contact and usually static. That eccentric occlusion is a static relationship.